Hello again. In this part of the lecture we will talk about the NeuroVision treatments, what are the treatments like, and the clinical protocols, what kind of examinations should be done before, after, and during the NeuroVision operation. What is a NeuroVision treatment? A NeuroVision treatment is a series of interactive computer-based visual exercises. It's done in front of a computer, as you can see here in this photograph. It should be done, by the way, in darkness. We turn the light on here just to take the photo, but the patient should sit in complete darkness in front of the computer. It uses visual stimuli to reprogram the brain to see sharper. Patient should sit 5 feet away from the monitor, or 1.5 meters away from the computer screen. It's not just normal walking distance, it's a bit further, and there will be always displays of series of 2 flashes on the screen where the patient should select which one is right and which one is wrong. The display patch, the display's flashes will be built using these Gabor patches, as you've seen here and as we've seen in previous lectures. How long does it take to complete the program? Actually, they need to do treatment sessions which take about 30 minutes each, about 3 treatment sessions per week. It's very important to do it regularly, like any gym program or diet program. You must do it regularly. We recommend 3 times a week for the most effective treatment program. Every few treatment sessions, we recommend every 5, to go back to the clinic to do a visual acuity test and see the progress and make sure that the treatment is actually effective. In average, it takes about 30 treatment sessions, so it can be completed within 10 weeks, about 2 to 3 months. For some indications, it may take less. For others, like amblyopia, it takes usually about 40 to 50 treatment sessions. What we actually get is a skill that the brain learns, like riding a bike or learning to swim. Once you learn it, you never forget it. So what are the products we have? We have the low myopia program, which can benefit customers with mild degrees of myopia or some residual myopia after LASIK or other refractive surgery operations, which means a myopia of up to minus 1.5 diopters and astigmatism up to 3/4 of a diopter. Emerging presbyopia, those who just started using or about start to use reading glasses with a near addition of up to plus 1.5 diopters. We're talking about those in their 40s. They started needing reading glasses and they want to delay it by a few more years. Other treatments that we have, like children myopia, post-refractive surgery, adult amblyopia, we have the supervision, the sport vision, and the post-cataract surgery. In means of the different products that we have, you can see that we have actually different categories. Those that are more lifestyle, like the presbyopia, the low myopia, the supervision, or the contact lens enhancement, which aim to improve quality of vision to people that have normal vision but either want to have even better vision or just want to have it without any visual aids. We're talking about the enhancements product, like our post-LASIK or post-IOLs that can be bundled or enhance the results of a surgical operation, or those that are for pathologies, people who have some kind of a pathology that affects their vision. With the amblyopia product that we have, it can be the macular degeneration, glaucoma, optic nerve dysfunctions, and so on. It's important to understand that the NeuroVision is actually a platform technology. It creates a new category in vision correction. That's visual correction of the brain system, the visual system in the brain. It's the world's first clinically and scientifically proven of a non-invasive vision improvement treatment. There are a lot of eye exercises out there in the market. None of them have any solid scientific or clinical data to prove its efficacy, which NeuroVision do have. It enhances contrast sensitivity and visual acuity. It's non-invasive. There are no medications, no drugs, no risk. It's computerized. It's based on the internet, but it's not a www.neurovision.com. It's a software you install at home, and it uses the internet to automatically communicate with the data center where the very smart, so to say, algorithms are. And it's safe, it's efficient, it got an FDA approval, and it got a CE mark approval. So let's look again at who can benefit from NeuroVision. Our first indication here is for amblyopia, those with age between 9 and 55. They have unilateral amblyopia, which may be anisometropia, it can be strabismus, or it can be a combination. Their best corrected visual acuity between 6.9 to 6.30. If they have any strabismus, it must be mild eye deviation, not more than 8 prism diopters. If it's more than that, it needs to be corrected first. They need to be motivated and committed. For the low myopia, the mild myopia or post-LASIK, we're talking about age. We say here 10 to 55, but the most important thing is that the myopia is stable with spherical refraction of up to minus 1.5 diopters. Astigmatism, actually it's a mistake here, should be up to 0.75, 3/4 of a diopter. Unaided visual acuity, distance unaided visual acuity without any eyeglasses should be between 6.9 to 6.24. There shouldn't be more than 3 lines of difference between the eyes. If there are more than 3 lines of difference between the eyes, then probably without eyeglasses they will have unilateral vision. They will just use the better eye. Unless the patient is keen to improve the better eye only, we recommend not to take those with more than 3 lines difference between the eyes. Their best corrected visual acuity should be normal in order to eliminate any other visual pathologies or issues with their best corrected visual acuity. Again, must be motivated, disciplined, and committed to do the treatment. For presbyopia, we're talking about emerging presbyops, those who just started using reading glasses or about to start using them, people in their 40s or early 50s with uncorrected near vision between 6.9 to 6.24. When I say uncorrected near, it means when they're using whatever they're using for distance. If they don't wear anything for distance, and of course without any eyeglasses, if they wear contact lens or glasses for distance, just by wearing their habitual distance glasses, they should have near VA between 6.9 to 6.24, addition that is up to 1.5 diopters. Sports vision, we're talking about people with normal vision that are very highly aware to their quality of vision and very keen to further improve it. When we look at the exclusion criteria for the different conditions, and actually these include exclusion criteria apply to all our treatment products. Any other eye diseases or complications will exclude the patient's eligibility, so it should be only the condition that actually requires the treatment. People with diabetes, which may cause fluctuation in vision, epilepsy, severe migraines. Pregnant women, we recommend to do it after delivery, because pregnancy itself may induce fluctuations in the quality of vision that may actually affect our algorithms. And those with different concentration problems that simply cannot sit half an hour and do the tasks in front of a computer. When we talk about the examinations, first we're talking about examinations of visual acuity and contrast sensitivity. These are our main quality of vision measures. When we talk about amblyopia, we're talking about best corrected visual acuity and contrast sensitivity. So we check the quality of vision with the best possible correction for the patient. This will also be true when we talk about different pathologies like glaucoma, AMD, and so on. When we talk about myopia or post-LASIK, we will talk about distant quality of vision, but unaided without any correction. When we talk about presbyopia, we're talking about uncorrected for near, so whatever they're wearing, just without any addition for near. And when we talk about sports vision, we're talking about the habitual, whatever they're wearing, we just want to push that a bit forward. Typically, we'll also do the objective auto-refraction and subjective refraction. Optionally, also the cycloplegic refraction when we want to be more accurate. For amblyopia, we will do a complete ocular examination just to make sure that the source for the poor vision in the amblyopic eye is amblyopia itself and not any other eye pathologies, and typically also orthoptic examinations of the degree of eye deviation and binocular vision examinations, which we do only for amblyopia. So what the treatment procedures are like. The inclusion criteria itself. For early presbyopia, which is one of our main applications, we're talking about age 40 to 50, sometimes up to 55, with uncorrected near visual acuity between 0.2 to 0.6 logmar, that's between 6.9 to 6.24, not more than 3 lines difference between the eyes, and those that have experienced recently difficulties in reading, where they don't really wear the near vision correction yet, or just started using them. For myopia and post-LASIK, which is the other main product we're talking about age 9 to 55, where actually the most important thing is that myopia is stable. Best corrected refraction must be up to 1.5 diopter spheric and up to 3/4 of a diopter of astigmatism. Unaided distance vision should be between 6.9 to 6.24. Again, that's unaided without any correction, and not more than 3 lines difference between the eyes. Very important for both presbyopia, myopia, and actually for every NeuroVision treatment, that patient is cognitively intact and is able to follow multiple step instructions, especially important when we're talking about children. The patient is able and willing to attend all study sessions and visit at the required frequency. It's very important to comply with the treatment schedule and to be motivated and try to do and put an effort. There is a lot of effort in these treatment sessions, so they should understand that the total number of sessions would be about 30. Again, for amblyopia, it can be even more than that. The required pace for the treatment session is an average 3 sessions per week and at least 9 sessions a month, but we strongly recommend to do 3 sessions a week, and no foreseen interruptions longer than 2 weeks during the treatment course. That would require restart of the treatments, especially if the interruption is relatively at the beginning of the treatment procedure. Exclusion criteria, as I mentioned before, but here it's just more detailed. Any other eye diseases that causes the reduced visual acuity aside from the presbyopia, hyperopia, myopia, or astigmatism. So any other pathologies would exclude, unless this is a specific pathology that we're trying to treat with this treatment. Other visual complications resulting in the visual loss, such as AMD, cataract, any other retinal conditions such as retinal detachment. Diabetes will exclude if they have previously undergone refractive surgery in either eye, again, unless we're talking about the post-LASIK treatment type. Pregnant patients, those with migraines or seizures, epilepsy, any medications that they may take that may cause visual fluctuations or they affect their ability to concentrate, dizziness, and so on. Any emotional status that may impair their ability to perform the treatment. I don't know, if a patient is going through a nasty divorce, I would recommend to do the treatment later on when they have their peace of mind, and do the treatments with the right motivation and concentration and compliance. So what do we actually test? At baseline and end of treatment, we are checking eligibility, and we're taking the baseline quality of vision measures. For presbyopia, we're looking at the current glasses or contact lens they're wearing. the subjective refractions for distance, and then also the distance visual acuity, the subjective refraction for near, and the near visual acuity and near contrast sensitivity, and for near visual acuity and contrast sensitivity we will check the best corrected, and we will check the uncorrected without any addition for near. For the low myopia or the post-LASIK, that's a bit easier because we're talking only about distance vision here. Again, the current glasses they're wearing, their subjective refraction, unaided distance visual acuity and contrast sensitivity, and best corrected distance visual acuity and contrast sensitivity, we would like to try and to measure the improvement in both. For the amblyopia, we take the subjective refraction for distance. We look only at the best corrected distance visual acuity and distance contrast sensitivity. We're not interested at all in unaided acuity here, only the best corrected. We check the type of amblyopia, the eye deviation with a simple cover and cover tests to make sure that it's not more than 8 prism diopters, and we do the binocular and stereopsis tests such as Worth for dot, and 3-dimensional tests such as the Titmus fly test or the Randot test. For sports vision, we will check the refraction for distance, of course, and the best corrected distance vision. In case that their habitual correction is not a full correction, we will test also the habitual distance visual acuity and contrast sensitivity. In the periodic examinations, we're looking at the main outcome and to check the progression of the main outcome. For presbyopia, that would be the uncorrected near vision, which means their correction with their distance correction, but without any correction or any addition for near. For low myopia and post-LASIK, we're talking about unaided distance, so simply without any correction, the distance visual acuity and contrast sensitivity. In amblyopia, it would be the best corrected distance visual acuity and contrast sensitivity with the best correction. And in sports vision, it's the habitual distance, which may be the best corrected, but not necessarily. We also have quality of vision questionnaires that subjectively check the quality of vision and the improvement in vision as the patients experience them through the sessions. We have one that we give out at the baseline just before they start the treatment, one which is intermediate when they're about halfway through the treatment and they do it after 15 treatments, and one at the end of the treatment that summarize the improvement as they feel it throughout the treatment sessions that we give at the end of the treatment examination time. These are just examples. The visual acuity tests that we're doing, we're not using the standard Snellen test, but we're using the ETDRS charts. That's just an example for an ETDRS chart. These are more accurate, they are very proportional, very standards, and they're getting to be more and more the standard of care in many practices. For contrast sensitivity test, we're using grading-based tests. We're not using letter tests such as the Pelly-Robson, but instead we're using those based on grading. It can be like this one, the sine wave contrast test. It can be the FACT test. It can be the I think vector vision test. It can be a chart, a wall-mounted chart like this one. It can be using a machine such as the optic or the functional vision analyzer machines. As long as it's a grading test, that's accepted by us. This is all for this lecture. Thank you very much, and wish you success with your NeuroVision operation.